who are viewing now in real time or maybe later on enjoy what we have to say and find it informative. So without further ado, apologies for absence. I haven't got any apologies to me. I think everybody is here. We've got a full head count, so everyone's welcome. Declarations of interest. If you have any updates, please let Jenny Jones know. If there's anything on the agenda you feel that there's a conflict, please raise that, and if necessary, remove yourself for that item. Is everybody okay with that? Anybody to declare anything? No, thank you very much. We'll go to the minutes of the meeting held on the 18th of May. It has been round for corrections, but has anybody else got something that we've missed that they'd like corrected? No, thank you very much. That's great. And looking at the minutes and the action log, are there any matters arising, please? No. Okay, that's great. So are the minutes approved? Yeah. Okay, that's great. Thank you. So we're now going to have our staff story today, and I'm really pleased to have some colleagues from Pharmacy Services with us today, because I think, you know, having you both here today, Anna and Kerry, I've been really impressed on some of my visits, meeting some of your colleagues and seeing how some of the changes, really proactive and innovative changes, have happened in the service. And I'm sure you know this already, but just to feedback to you, not only hearing about how much better it has been for our patients, but also how other staff members, allied staff members, have found having you working alongside them in this way so productive and so helpful. So I hope you've heard that from them, but I just want to put that on the record. And so every time I do an inpatient visit, you know, meeting someone from the pharmacy team is always something that I look forward to and make sure I hear from them. So we're really delighted to have you today. John, do you want to just introduce, and maybe a bit of context, particularly for people looking in who may not know about what happened in the service?
No, absolutely. And just if you just forgive me, just let me start with a story about my Damascene conversion to the joys of pharmacy, because my days as a junior doctor back in the 90s and stuff are haunted by pharmacists standing over me with a green pen, looking at medication charts I used to write out, and basically questioning my sanity as why I wasn't able to follow the BNF. And I see, Anna, you're smiling at that, because clearly you've taken a few junior doctors to task over your time, because if you haven't done that, you're probably not a proper pharmacist. But anyway, I think over a period of time, as one gets a little bit older and a little bit wiser in healthcare, you start to realize that healthcare just isn't about doctors and nurses. And I think there is a public perception that healthcare is all about doctors and nurses when it's not. And in some ways, we miss out the opportunity to think about and celebrate the wide range of allied health professionals and other professionals who work in delivering healthcare. And you know, the NHS has been missing a trick for a long time, particularly when it thinks about pharmacy and the role of pharmacy, because perhaps back at the turn of the century, the role of pharmacy was seen very much about reducing costs, as opposed to necessarily be proactively about treating patients, improving services, and increasing medication optimization. So I'm pleased to say that the pharmacy colleagues in our organisation, whether pharmacists or pharmacy techs, play a fundamental role in delivering our services at a community level, but also an inpatient level, right across the trust. And, you know, we'd never have delivered a vaccine over the last 18 months if it hadn't been for our pharmacy colleagues. So I'm really pleased to see that the role of pharmacy, its profession, and pharmacy techs is now seen across the wider NHS as being really important as to how we transform services going forward. But I'd like to say that in Humber, I think we were probably ahead of the game 3 or 4 years ago in terms of transforming our services and capturing the skill set which people bring. And Caroline, it's just brilliant to hear you say that actually everywhere you go, not only are you excited about actually talking to the pharmacists and hearing about what they do in the pharmacy techs, but the feedback from our colleagues, nursing and medical, about the role of pharmacy within our trust and how we provide services. And their nirvana here is that soon, hopefully in the next couple of years, we will start to see that feedback coming directly from our patients through the national patient surveys, which we talk about here at board. So look, you know, if you took pharmacy out of the trust tomorrow, we would probably fall over very, very quickly. I'm delighted that we have Anna and Kerry here to talk about what they do and how they do it. And hopefully it'll provide some inspiration to our other allied health professional colleagues who do equally fantastic work and do stuff now which we wouldn't have been doing 5, 10 or 15 years ago, so that everyone can see that healthcare just isn't about those of us who are doctors and nurses. Thankfully, it's broader and much more inclusive than that. So over to you and Anna and Kerry.
So, who's going first? Make sure you're not on mute.
Well, classically,
We want to hear from you.
On mute while trying to multitask there. So I'm Anna, one of the pharmacists with the Scarborough and Rydal Community Services. I have done a presentation, so bear with me while I hope I can share my screen quickly with you for you to see what it is that we do. And it has failed me. One second. I might try that again. So essentially what I will do today is I'll just be talking you through my background and how I've ended up in the trust, and then what I do, and then I will be passing on to Kerry to present what the technicians do. So let's see if that works. If you can kind of let me know when you can see that, that would be great.
Anna, if you want to send me the presentation, and I'll see if I can open it while you're just we will talk amongst ourselves. Well, if you can just email me the presentation, and that that'll be one less thing for you to have to do. Oh yeah, you're up and running.
We have it. There you go.
You can see that good. So essentially it is what is a clinical pharmacist. Now, I qualified in 2013, and when I qualified, it was quite scary to end up on an acute ward once you've qualified, going, that's it, you're the pharmacist, good luck. When you've just done 5 years of uni where you don't have that much patient direct interaction. So it was petrifying to end up on an orthopedic ward, and I was the pharmacist. I worked with York and Scarborough Teaching Trust for 6 years. So once I qualified, I did a postgraduate in clinical pharmacy in a hospital setting. And as a diploma pharmacist, I was responsible for several wards ranging from orthopedics to acute admissions to elderly care to gastro. So I rotated through the wards, and I was responsible for the patients on the medication they got, the clinical reviews of their medicines when they were admitted and such like. From there, I moved on to being one of the pharmacists in the EPMA team, so the Electronic Prescribing Medicines Administration. So depending on where you are in the trust, if you're in the mental health inpatient units, that'll be Lorenzo. If you're on the community units across the Scarborough-Rydal side, that'll be System 1. Working with the York team, we were initially involved in the whole building the system up before Scarborough and York went live with their CPD system. So I was the lady in the background adding all the drugs to the prescribing screens, making sure the doses were appropriate, the interactions had been checked, the correct quantities, and alongside that, I still had to work my normal wards. So at that point, I was looking after elderly medicine. From there, I moved on to education and training. So I went from being the EPMA pharmacist to being responsible for the on-site training of pre-registration pharmacists, as well as summer student pharmacists, as well as nurses who newly qualified or training nurses who wanted a quick run through pharmacy and what that entailed, as well as HIM students who were going through their training when they needed to spend some time with pharmacy. So there was a lot of multi-skilled juggling. Alongside my postgrad in clinical education, in clinical pharmacy, I did a postgrad certificate in clinical education. So technically, I could be a teacher, but I quite like seeing patients. I'm not all that fair with students. I currently work in community services. So this is a bit of an unusual role because we're quite used to seeing pharmacists in GP settings and community pharmacists that's in your local pharmacy. However, pharmacists in community services where you're working alongside the district nurse teams, the community physios, OT, such like, it's quite unusual. So I do get a lot of questions of, oh, are you from my chemist? And it's like, no. When you see your district nurses, I work with them. Your GP refers into us, and then we come out and see you. So that's my background. As opposed to what I do, predominantly I'm seeing your frail, elderly, housebound patients. Those are the main cohort of patients I see, and those patients we do a structured medication review for. So looking at their medicines in detail with the patient as to what they're on now, why they're on it, do they still want to be on it, are they even taking it in the first place, do they and their family understand the implications of taking something or not taking something. And at the same time of that, we take part in providing pharmaceutical advice to our community services colleagues. So an example of that is working with the speech and language team when they've got a patient who's got swallowing difficulties. And they've already made amendments to what how they should eat and what the thickness of fluids, and they'll come to us with the question of, well, what do I do with their medicines? Do they need crushing? Do I need to change everything to liquids? And having those checks and getting back to both the teams and the patients so that everybody's on board. Because if your patient isn't taking their medication, then everything you've prescribed, they're not getting the benefits. And at the end of the day, you want patient-centered care, and part of that is making sure that the medication they're taking is suitable for them in whatever form they need it. And taking part in MDTs, so sometimes we'll work quite closely with our GP teams, making sure that if they're struggling with getting time to go speak to a patient about certain changes to medicines and such like, we can go out, do those visits, get the information back to them so that we can have those discussions about the continuation of care. And also post-discharge, because quite often you get patients through no fault of their own and through no fault of their tutors have been discharged without them fully understanding what's happened with their medicines. So they go in with 1 or 2 tablets and come out with a bag of medicines, and quite rightly, a lot of them, especially the elderly patients, freak out and go, what do I do with this? Should I take it? Should I not take it? What am I doing with this? And so once they discharge, again, we get a referral in, whether it's via System 1, which we work with across Scarborough-Rydale, or whether it's a telephone call from the GP teams themselves or our community team saying, we've been in, this is an issue, can someone go? And we'll go and we'll discuss with them anything that is being stopped, but they still have. We'll get verbal consent from them to return to local pharmacy so that the patient just has at home what they need to take. They understand why the changes have been made and what they are taking. And that is a tip of what I do, but it's quite a succinct summary of what I do. Now, pharmacists have many bases. So you've got the specialist pharmacists like myself, who will specialize in a specific area. You've got your generalist pharmacists who are have to know a bit about everything, and you will see them in multiple settings. You've got your independent prescriber pharmacists who, again, specialize in a specific area, but they will prescribe as well, which crosses the borders into your doctor land. And you've got pharmacists who train as ACPs. Now, it's quite common to see an ACP as a nurse, as a paramedic, but a pharmacist ACP is not all that common. They do exist. And it's quite useful to know that you've got a colleague who specializes in medicine who can also give you a hand in the physiological part of the patient care. We also get consultant pharmacists who, again, specialize in their specific area, and they will run clinics. They will run the same way you have a consultant doctor, consultant nurses have their own caseloads, look after their patient. You have consultant pharmacists as well. I will briefly crouch onto Kerry's patch and say our technicians also cover quite as big a range as our pharmacists do with medicines, those who specialize in medicines management, those who specialize in clinical governance, those who work specifically on the ward. You've got your principal techs who manage the technicians overall, and you've got our techs who work in medication safety. And this is just a small sample of the amount of variety you can get within pharmacy. On that note, I am going to bow out, Kerry, and you are up next.
Thanks, Anna. Kerry.
Thank you, Anna. I will just share my screen. Sorry, I'm also having problems. Sorry about this. I don't seem to have the little icon that goes to share screen. Anna, can you help me out? Which bit did you go to?
Next to the mic, there should be like a little screen with a arrow.
Why didn't I see that? Right, okay. Right, can everybody see that?
Yeah.
Yeah.
Fantastic. So good afternoon, everybody. My name is Kerry Finch. Thanks for having me today. I am slightly nervous, I must admit. So I am a medicines optimization technician here at Humber. So I'm going to give you a bit of an overview of my sort of pharmacy background and how that led me to where I am today. Talk about my current role and then talk about how possibly I'm looking at expanding the current role as well moving forward. So just a bit of background of who I am. So I'm a GPHC registered pharmacy technician, General Pharmaceutical Council. I actually started my pharmacy career in 1993 when I was actually 14. I got a Saturday job in a chemist, the local chemist, and that's where my love of pharmacy began. And here I am many, many years later. I actually trained as a pharmacy technician at Hull Royal Infirmary. It was a 2-year training post. I did a BTEC in pharmaceutical science, in-house training, spent 2 years there and qualified in 1998. It's still to this day very, very good training package at Hull Royal Infirmary. You get to sample all different areas of pharmacy, procurement. I worked in the aseptics unit for about 6 months, making chemotherapy. So lots of different areas, outpatients, inpatients. So it was, I think it's a very good training package and stands you in good stead for sort of all aspects of pharmacy, really. So I was at Hull Royal for about 7 years altogether. I actually moved location at that time, and I worked in hospital in Northampton. This is where I sort of was first introduced to medicines management, or medicines optimization as we call it today. My job there entailed working on an acute assessment unit. So I was working directly with patients, assessing the medication when they came in, the patient's own drugs, making sure that what was prescribed, was correct, checking the patient's GP records. So that was my first taste of it, really. And that's when I realised that was the part of pharmacy that I really enjoyed, that patient contact. So I returned to the local area. I initially went back to Hull Royal, and then I was enticed to come to Humber in 2007. So when I first came to Humber, the role of a pharmacy technician was quite different. We were very much we were quite audit based, really. We would visit the unit, the inpatient units, but it was more to do with completing audits. It wasn't really a part of the actual team on the ward. So it was a little bit more office based at that point. I had a career break for 5 years when I had my 2 children. Within that time, because I wasn't practicing, I wasn't registered with the GPHC. So when I decided to return to work in 2015, I contacted our chief pharmacist, Liat Chong, and was supported back. I worked on the bank as a pharmacy assistant, and then I was supported by the pharmacy team at Humber to revalidate as a pharmacy technician. I felt very lucky to have that opportunity. And then in the meantime, I also worked in a retail pharmacy whilst I was doing bank work as well, which was actually Lloyd's Pharmacy, who used to provide the pharmaceutical service contract for Humber. So I then got a substantive role at Humber after revalidating. I've had various different roles. Quite honestly, I've been really lucky. There's lots of opportunity with Humber, and the pharmacy team support everyone. So I've had a few different roles, really. I've had a principal technician role, which was more of a managerial role, but my heart definitely was in a role that was patient facing. So when the pharmacy team, we decided to look at more of an in-house service when we terminated our contract with Lloyd's. This was when we looked at having pharmacy technicians actually on the wards, dispensing medication on the wards. So this is what led to my current role. So I'm a medicines optimisation technician at the Inspire CAMS inpatient unit. That unit opened in January 2019. It's a fantastic building. So I initially, when I started the role, it was a very traditional role of what people think a pharmacy technician would do, which was obviously order medication, administer medication, monthly audits, control drugs, that sort of thing, planning discharges and talking to patients about medication. It soon became apparent that whilst on the ward and whilst, sort of being patient facing, it was a really good opportunity to build up a really good therapeutic relationship with the patients. And because I was quite consistent, presence as well, 4 days a week, it became apparent that there were possibly a lot of other areas that I could help with on the ward or being part of the team. So within the last 2 years, I've been trained as a phlebotomist, physical observations. I've done ECG training, also administering IM medication. So if we've got a patient that's on a depot, I can administer that. I can also administer medication for rapid tranquilization. I'm DMI trained, so I'm part of the team that obviously responds to help the team, to support the team. And then I'll also take part in supportive engagements with the patients. I'll go with the patients on leave to appointments. And what I sort of found was because of that therapeutic relationship, you build up quite a good trust with your patients. And I think a lot of our patients maybe didn't trust people. Obviously, I work in CAMS, so a lot of our patients have come from quite traumatic backgrounds and really didn't want to trust people. So it really can take time to build up that therapeutic relationship, get that trust, and obviously linking that in with them taking the medication, trusting me when I talk about medication and explain how they can be empowered by having knowledge about their medication and when they take the medication, and just having that knowledge and power of understanding how they feel and understanding that although medication's not everything, it can be a part of their journey, and it can be a part of helping them, empowering them to get home and stay well. So my role's completely changed really within the last couple of years, and I think I feel so much part of the team, and I think that's all the pharmacy technicians that you speak to, that's what they'll say. We sort of started off well, I joke and say that when I first went there, they didn't know what to do with me, and now they don't know what to do without me. So, which is really nice. And when I come in on a Monday morning, they're always so pleased to see me. That, oh, thank God you're here, and that it's so nice to have a job like that. I must admit, it's really rewarding and really feel like a part of the team. And then obviously seeing that patient journey from start to finish, seeing those CAM patients come in, who barely want to speak to you, and they're so shut down, and being part of that, of their journey, of getting that trust, talking to them about medication, and also obviously talking to their parents and carers, because obviously, the CAM patients are under 16. That's a really big part of it. A lot of parents are quite reluctant for their young people to take medication. I completely understand that. So I have a lot of contact with parents, obviously sharing patient information leaflets with them as well, being part of any discussion about medication, talking to them about any worries or issues they may have. And that also extends to discharge as well. So a lot of the time when our young people are discharged, I'll make sure the parents know they can contact me at any point if they want any sort of discussion or any advice. And we just try and make sure that obviously the transition of being discharged or, and going home is as smooth as possible. And obviously medication, making sure there's sort of concordance and compliance to make sure our young people, stay at home and stay well. It is really, really important. So within my current role at the moment, I'm actually on a secondment. I started this secondment in January this year as a trust medicine safety officer. I've been doing that secondment 2 days a week and still working on the ward 2 days a week. Just to give you a brief overview, the medicine safety officer is a statutory role in all NHS trusts. So since March 2014, following the an NHS National Patient Safety Alert, every trust had to have a medicine safety officer, and that was the aim, was to help all healthcare professionals increase the quality and frequency of incident reporting for medication errors. So I've been doing this role now, say 2 days a week. I'm going to be starting the role 4 days a week, still on secondment at the beginning of July. So basically, so with my med safety role, I manage the medicine safety team. There's 4 of us. There's myself, 2 other pharmacy technicians, and also a physical health nurse. So we've got a lot of background in all different areas of pharmacy and nursing as well. So we, as a team, we review all the medication incidents that come in daily. We attend the patient safety huddle. Every incident is discussed. Obviously, the main aim is to identify how and why the medication incident has happened. And then we are looking at areas for change or improvement. And this is looking at obviously recommendations to ensure, we're delivering obviously the safest possible care to our service users at all time. So within the role, I attend the weekly critical risk management group meeting, where obviously we discuss all the incidents, any that have been escalated, that have gone to possibly initial incident reviews, obviously looking in more detail to look at root cause, and obviously then look at learning outcomes. How can we ensure that this incident doesn't occur again? So within the role, I'm sort of trying to promote reporting. I know it's difficult. The staff are really, really busy. It's not a short process filling in a DATIX, but obviously it's really important that we do, share incidents. So it's a case of sort of building a culture around reporting and the safety of medication. And I think the CAM staff I work with have got a fantastic culture like that. So I'm taking quite a few tips from that to try and expand it across the trust. Obviously, it's sharing our learning, sharing the incidents and the outcomes. We're looking at obviously themes or trends to see if there's any way we can proactively, introduce, a different approach. We're looking at being sort of proactive rather than reactive. So we produce reports monthly as part of the medicine safety team for every division. These reports go to all sort of clinical leads, make sure they can actually see their own incidents, see what's going on, and make sure we can sort of learn from that. So now that I'm doing the role 4 days a week, I'm looking at how I can expand it and in what ways, now that I've had a bit of a taste of it, sort of look at how we can how I can expand it and, you know, sort of be more efficient and basically safer, I suppose, because that's the main aim. So I'm going to be spending 1 day a week on an inpatient area, or patient-facing area. So I'll visit all areas of the trust, inpatient community teams. Hopefully Anna, I'll spend a day with Anna, hopefully, up in Scarborough, Rydale. Obviously, we've got Whitby and Malton, our community inpatient wards as well. So it's just a case of being out there, basically, being visible, you know, making sure that I'm visible to staff and all of our service users. I think being sort of on the ground, sort of shop front, is really important with medicine safety, to ensure that it's great having policies and procedures, but obviously you need to know what's going on, how things actually work at the coal face, as they say. So I'm going to be working more directly with our pharmacy staff. And again, it's all about promoting lessons learned, outcomes from not just our trust, but obviously other trusts. I joined a regional medicine safety officer group where obviously then I can look at other incidents in other trusts. Are there other themes, are there things that we can look at proactively to make sure maybe we don't come across those errors. And then also looking at commending good reporting. It's so important to report and, just to commend our team. So we're looking at maybe a monthly picking an area and, just commending them, really, just to say, thank you for your reporting. It's so important, to the whole aspect of medicine safety and the trust and what sort of ethos we want, really, this sort of safe culture that we want. And a big area we're looking at the moment is near misses. And I think that's what I'm hoping to pick on when I'm out and about now, visiting everywhere, is especially with obviously we've got pharmacists and pharmacy technicians now on every inpatient area or attached to every team. So I think, they might pick up things that possibly could lead to an error. And I think it's really important that we capture that. So we're looking at near misses, could this potentially be an error? So if that's the case, let's do something about it, now, to sort of hopefully, build on that, really. So I've got quite a varied role at the minute. So they're 2 days on an inpatient ward, 2 days in med safety. I was part of the COVID vaccination team as well, which meant that I could then vaccinate our young people on the ward, which was fantastic because a lot of them were very reluctant. But when they found out I was doing it, they were like, "Oh, right, I'll have it then." And then I was able to vaccinate all these staff with flu vaccines. I think we had much bigger uptake because a lot of the staff didn't have to, on the day off, go to get a vaccine. They could just do it on shift. So really, my role's just expanded unbelievably, really, in the last couple of years. And I do feel really lucky that I've had this opportunity to sort of, learn so many new skills and, and apply that to my job, really. But I think the biggest thing out of it for me is, as I said, being part of that journey. Sort of working in CAMHS, it's been such a rewarding role, and I do feel very lucky. I must admit that I've been able to be part of it all. So I think that's about it from me. I feel like I'm rambling now, but thank you very much. Thank you very much for listening. I really appreciate it.
Thank you so much, Kerry and Anna. I love the fact that your journey started working on a Saturday in the chemist. How many of us started our journey on a Saturday job in life? I'm sort of, as you were saying that, I was thinking maybe we need to do some mystery shopping in some of the chemists locally for the future Annas and Kerrys. But thank you so much for that. And also having both of you here, so we could sort of learn a bit more about both the community side, but also the inpatient side of the service and what you do. I'm sure there's lots of questions from people for you. And I can see Hilary.
Off my mic. Thank you, Caroline. What a fantastic presentation from you both. I wish when I'd been in clinical practice, I'd had a Kerry and an Anna working with me. Obviously, all those years ago, pharmacies were, as you described, they were when you were first qualified. What you're doing is amazing. You are dealing with patients, you're dealing with the physical health needs, you're dealing with waste, which is a big issue, obviously around medicines, but they are very expensive if they're not taken, and then if people are bouncing back into the acute trust, as well as costs associated with all that. So what you're doing is really starting to address those issues. And again, I think for the board, we've got the Safer Staffing Dashboard, haven't we, which we look at every month. That focuses on registered nurses and healthcare, but you can see from what Kerry and Anna have said how important their roles are as well in those multidisciplinary teams. We don't pull them through into that Safer Staffing Dashboard. We're trying to address that, but it just shows, when we're looking at some reds and things there, it's not taking account of the fantastic work that our pharmacists are doing out there. I was going to ask you what next, but I saw that you'd got your slide there with what you were doing next. I don't know how you've got any time left, capacity left to even do it, but it just shows the enthusiasm from the team, doesn't it, to keep pushing those boundaries. But in terms of what next, are there any barriers that you're coming across in terms of being able to really push forward, or are you pushing against an open door? Is there anything that you need the board to help support you with? So just really over to you if there's anything on that for either of you.
Kerry, do you want me to take that one, and then you can?
I guess, I mean, at CAMS, my role is a part-time role, and I do think it would benefit possibly from a full-time role. And obviously weekends are not covered because it's a Monday to Friday role. So I know a lot of the staff say, "Oh, I wish you were here on a weekend," or that sort of thing. So I guess maybe in the future it could be good looking at sort of shift patterns for pharmacy technicians, a bit like the nurses and the healthcares, to see if we could possibly get a bit more coverage.
That 7-day service, isn't it? We need to be getting behind, yeah.
Yeah, I think so. And I think pharmacy's very traditionally been 9 to 5, hasn't it? But that we've moved on so much now. And like you said, we are very much part of the team. And I do think, and I do think on a weekend, like every trust, we are using a lot of agency staff and bank staff, which obviously is an issue across the country. So what I found is with medication errors, you do find that they crop up more on a weekend and out of hours. So I think having that pharmacy support on a weekend would possibly something would be very beneficial.
Great,
thanks, Kerry. Anna, did you want to add anything to that?
Yeah, from a community services viewpoint, as a pharmacist, it's quite innovative for the trust to have a team out with the community teams. But I think it would be useful to have that across our community teams, because at the minute we are just limited to, well, I say limited loosely, to Scarborough and Rydale. So when I'm speaking to my colleagues in Bridlington, in Filey, I get, "Oh, that's lovely. Do you come across to us?" And I'm like, "No, I can't, because where my boundaries are technically by the services offered, I can only provide to this geographical area." So I think thinking about for our community teams across the board, maybe considering implementing that across board, because I think our patients have found it very useful to be able to speak to someone for a set time about their medicines in depth and why they're taking it and what the implications are. And a lot of the times we tend to find someone's been on medication for years, and that conversation of, well, actually you no longer need to be on that because your circumstances have changed, or do you even remember why you were started out in the first place? Are you just taking it for the sake of your doctor said you should take it, so you're taking it? Having those conversations and feeding back to the GP teams and being almost like the middleman between the teams would be useful across board rather than in just one specific area for the trust. And also pushing possibly for the pharmacists as much as possible to get that independent prescribing or that ACP roles, because like Kerry was saying, she's well integrated within the ward teams with the additional help she provides, but not from a pharmacy's viewpoint. Not all the pharmacists are trained up to provide those kind of services, and it'll be useful across the board for everybody within those patient contact roles to be able to provide those services, if not similar, just to help out, because as lovely as it is to say I'm pharmacy, sometimes I do find it gets quite archaic because he's like, oh, you're the pharmacist, you just deal with meds. No, I can do much more if you let me do much more. So I think pushing for that and working within the team to say, yes, it's lovely you have a pharmacist, what else can they do to support you would be really good.
Yeah, really important stuff. Thank you.
Thanks, Anna. I've got Francis.
Thanks both. That was fantastic, and I don't know why you were worried, Kerry. It was a really impressive presentation. You were an absolute pro. Just to say, what do you think is the biggest positive about bringing it in-house? What's the biggest benefit that if you had to pull one thing out of bringing it in-house?
I mean, there's lots of things, I must admit. Obviously, I worked within the trust when it was outsourced, and there were a lot of issues. So what happens now is, just to give you sort of a brief example, is that the pharmacist that I work with, so she sits in MDT. So she's sat in MDT, I'm in the clinic. She can basically email me and say, we're going to commence this patient on this drug. I can log straight onto the wholesalers, and I can have it there that afternoon. It's so, it's so quick. Whereas previously we'd have to, get an order form together, send that to Lloyd's Pharmacy. They then have to process it. And it would then be the following day. If it was out of stock, we wouldn't get to know. Whereas I can access 4 different wholesalers. I can look at different pack sizes. I can look at, sometimes we have patients that, for whatever reason, they are used to a blue tablet, and that's what they trust. So I'll make sure I can get that brand so we can carry on that, compliance. So it's just, if someone wants to go on leave, and for whatever reason, it's only just been organised, then previously, if we couldn't get the medication dispensed, it might be delayed, and obviously we want to facilitate leave. So, or if possibly patients waiting to get transferred, and all of a sudden we get a bed that we really need for them, and they need to sort of go within the next half an hour, I can just basically, and my pharmacist can prescribe the medication. I can get it dispensed and prepped within 10 minutes. So it's just, I think what it's given us is just, I think for patient care and for transition and everything, it's really just been fantastic. Really, it's there's so I could talk forever about how much better it is. It really is. It's just for say compliance for patients, and looking at aids and devices and that sort of thing that we can source. We've got control over it, and I think that's the main thing, is that we've got control over it. And knowing our patients, we know what's best for our patients. Now we've got a good relationship with them, and I think that is something that in-house has really been really important.
Thanks. Your passion absolutely shines through. It's beautiful. Thanks.
Well, I absolutely love what I do. I can't explain what it's like when someone comes in and they're so ill, and we had one girl that just didn't really speak the whole time, and then the day that she left, she said, "Thank you, Kerry," and it was amazing, to sort of see the journey that she'd been through, and we get cards made and presents left and stuff, and people write, young people write to the ward, saying thank you, and it's just I keep everything that I get sent, I keep, and it's I've got children similar ages, and I just think when I look at some of those young people and see what they've been through sort of in their childhood, sort of thing, and what they've overcome, and it's quite a privilege to work with them, I must admit.
Thanks, Kerry. That's great. Anna, did you want to add anything about what difference it's made?
Yes, sorry, I'm off mute now. I think having an in-house pharmacy team, especially with community services, I find people find it easier, because because of community service, you kind of, depending on where you are, you're sat outside the GP on a different building, a different site. It's easier to find a pharmacist and go, can you just do this for me? Or can you just check this for me? And not having that, I need to go find this person, to go find that person, to go find that person to do this, when I can find someone in the room across from me to say, can you do that for me? And you get a prompt answer, and you can provide that care is not interrupted, and there isn't that delay, like Kerry was saying. I think definitely having inpatient teams close to hand, pharmacy teams close to hand, I think has been very beneficial for where we are at the moment.
Thanks, Anna. I've got Lynn, and I've got Stuart, and I've got Hanif, and then Michelle. Lynn.
Thank you. Thanks, Anna. Thanks, Kerry. That was a brilliant presentation. I practically hear every day support for the added value that pharmacists and pharmacy technicians add across our services. So really appreciate that. My question, though, is we do want to expand, and I will take on some of those comments that you raised with Hilary about 7-day services and how services will develop operationally going forward. Those are developments that are in our sites and plans at the minute. But what we are obviously finding is that it's becoming more challenging to recruit pharmacists and pharmacy technicians. So how, in your view, have you got any ideas, how we make these staff choose Humber over the plethora of other opportunities that are out there for them at the moment? What would you say is the key to that so that we can recruit more?
I think from a pharmacy technician point of view, I think we need to home grow our own, basically. As I said, that's how I started at Hull Royal Infirmary, a 2-year sort of apprenticeship, and then sort of got kept on from there, basically. So I think from that point, I think it's something that as a pharmacy team sort of really is looking at. But I think that would be the key for pharmacy technicians is, get people in, train them ourselves, and look at maybe every 2 years, maybe at least 2 students. And then once they've sort of come in and they've seen how Humber works and the opportunities, I'm almost certain they'd want to stay after that time. Obviously, I can't really speak for sort of nursing staff or sort of recruitment, because I know it's a national problem, isn't it? I know we've got a few student nurses at CAMS at the minute that are nearly qualifying, and they're going to sort of come then for permanent roles. So that seems to be working really well. But yeah, as I say, I think let's grow our own, basically.
Thanks, Kerry.
Okay, Stuart.
Good afternoon, Karen. And I'm Stuart. I'm one of the non-executives. Thank you very much for your presentation. I'm learning a lot about what you do and very inspired by it. My question is actually probably more to Anna, but Kerry, feel free to add. It's about how you deliver your service in a world where, more and more people are getting used to these kind of interactions and online conversation. Do you feel you can be effective with people in this kind of virtual forum, or do you need to be kind of in front of them and look at them in the eye, as it were?
It depends on which patient I'm dealing with, because the majority of my patient cohort are the elderly, sometimes technologically challenged individuals.
Sure.
For them, they find it more useful to have me face to face with them.
Yes.
And when I do that, I tend to pick up other things that have been missed. For example, some of our elderly patients, one of the standard things that they should all have is attendance allowance, which helps them get their caring to support them at home. So you'll go in and you do a medication review, but while you're there, you'll notice when they came up to see you, they weren't exactly very steady on their feet. And then you ask that slight question of, oh, have you seen the physios anytime soon? No. Or yes, but it was a while ago. Or you get the question and you ask also, do you have anyone helping you at home? Do you have, and then we then direct off to social services, refer to our physiotherapists. So depending on the patient I'm seeing, so the majority will prefer face-to-face, because with COVID as well, they go, oh, I haven't seen anybody in ages, and you go and you just get offloaded on, and you have to unpick what their grievances are and actually tailor it to why you were there, and then direct appropriately to the teams they need. But some of our younger patients are more than happy to speak to you over the phone or just do a telephone, an online session with you. But I find, and that's I think purely based on where I am and the patient group I see, they prefer more face-to-face, so that at least they know who they're speaking to and they feel like they get something done, which it sounds odd because they've come from the generation where you had your own personal GP, they knew your family inside out, and a lot of them feel like that's lost. So you kind of give them that reassurance of, no, it's still there, but it's in a different form. But I'm just here as a face-to-face initial visit, and if I need to, I come back time and again. If I don't need to, I'll be in touch over the phone. But because they've seen you face-to-face, they are more willing to speak to you over the phone.
Yes.
So it's a bit of a fine act. It depends entirely who I'm supposed to be seeing and what they want. We have that first conversation of, do you want to do this face to face, or do you want me to call you or send you a link, and then we go from there.
Yeah, thanks. By the way, apart from almost just describing my mother's situation, you also remind us about the need for any professional or specialist to be aware of the issues of other specialist professionals, so attendance allowance or OT or sort of social community support and so forth. So thanks very much for that.
Thanks, Stuart. Hanif.
Yeah, thank you. And as colleagues have said, great presentation. I actually just wanted to pick up on that last point when you mentioned COVID, because the impact of it outside of pharmacy healthcare is well documented, and it's something we've discussed at length. But just really interested in hearing how it might have impacted how you operate within the pharmacy world, and if there's going to be any changes that we should be taking account of as we move forward with our forward planning, and particularly the integration of the two.
From a community services viewpoint, I think what we've got going now with the mix of virtual and face-to-face definitely needs to carry on. And bearing in mind that sometimes it won't always be possible to have virtual sessions. So making available the spaces for those face-to-face discussions to be had. And also factoring in that not all our patients can get to us, even if we do have those spaces. So allowing our clinicians to be able to have the freedom to do a home visit when appropriate, with the relevant support in place, because sometimes you want to do a visit, but because of the patient's circumstances, you can't, or their family aren't willing, or they're not willing, or they can't come to you. So you're kind of limited on how you approach them. So I think having that flexibility to consider all aspects of how do we deliver this care to this patient. If we have virtual systems, making sure that they're readily available to the patient, whether it's via links to phones, whether it's emails with or letters, or whether it's a telephone conversation, making sure our systems are robust for those conversations to be had. And if it's a face-to-face visit in a setting of our choice, making sure those are accessible to our patients. So those who are got disabilities hidden and visible, making sure the rooms are accessible to them. And those that we do have to have a face-to-face visit in their own setting, making sure our teams are suitably trained to see what is said and unsaid. Because sometimes what someone tells you vastly differs to what they are implying when you see their body language. And the classic one I tend to see is when I go to someone and I say, well, how are you getting on with their medicines? Oh, I take them every day. Can I see your medicines box? And you open the kitchen cupboard and it's crammed. And the date of the last one was like 96. And I'm going, yeah, no, you're not taking all your medicines. And I know you're telling me you are, but let's work with that. And that confidence of saying, look, it works and I understand, but maybe there's a better way to do it, but not infringing on their ability to say thanks, but no thanks. And then directing them to say, look, when you get to the point where you want my help, this is where I live. This is my contact details. Just get back in touch. And if we can train our staff to have that adaptability, I think we will go far with the services that we provide from a pharmacy viewpoint.
Thanks very much, Anne. I think that's a really, I'm really glad you said that, because it's a real reassurance to people that, the health service can provide a variety of ways to support you. And I was just thinking, when you were giving the example of actually, your point about our medicines actually being used in the way they want, and it's hard to know that if you're not there. But I was also thinking about, people living in fuel poverty as well. you don't really get a sense in that unless you're actually in the home and know what's happening. And I imagine this winter, maybe part of the general NHS winter plan should be to think about that going forward, given the price rises that are going on. Thanks for that and that context of what you do. Michelle.
Yes, thanks, everybody. Good afternoon, and what a great presentation. And I know I'm conscious of time, so I'm not going to repeat a lot of what my colleagues have said, because my colleagues have asked a lot of my questions, but certainly no need to be nervous. It came across fantastic, and what a great service, and the diversity of the service as well. And when we started on the journey in relationship to expanding the skill base and the pharmacy, who knew it was going to turn out to be so fantastic? And that's thanks to you and your colleagues, so thank you. I mean, it really has helped us on our transformational journey, and also I think the wider aspects of skill mix across the board. And I think what we clearly demonstrated today and clearly seeing is that improvement to patient care and patient service, delivery, etc. And I did have to have a bit of a smile when you mentioned about the cupboard and opening, because it sounds something like I've found in my father's kitchen and what have you. So you might get a job there, but seriously, we all know about the atrophic disease associated with multiple pharmacological products as well. So I think it is really important, as well as what you said a while ago around that educational piece with service users and the families. So just fantastic, really. We will take on board certainly some of the things that you've mentioned today at the exec team around rotoring. Obviously, you mentioned about being part of the multidisciplinary team, but there's quite a few things that I've written down. I'm sure my colleagues have as well, that we will pick up, and we will get back in touch with you about how our discussions have gone, because I think there's some really good key things about the next stage. I know that you've put in for awards and things, but let's remember that we need to tell everybody about this service, because I think others are struggling, other areas are struggling, and other trusts are struggling. So please, let's see if we can help support you in that and helping support other areas, because it does help patient care. But I could go on significantly, but just want to finally say that obviously some of the things that we did weren't without risk. Bringing the service in-house, moving to electronic prescribing, all of which you have managed in the face of a pandemic as well, because we were doing it alongside that phenomenally well. So thank you for making a difference. It is remarkable, and what a fantastic way to start our board.
Thank you, Michelle. Nothing more to say. We wanted to hear from you for a while now, and it was worth waiting for. Thank you, Anna. Thank you, Kerry, and have a great week ahead. Thank you so much.
Thank you.
Thank you.
Great. Good. Very good. Okay, moving on then to Chair's report. Just a few things to mention. I've met Councillor Linda Chambers, who is the new Governor representative from Hull Council. We had a chat recently. She's actually a nurse by background. So she's obviously got the brief on Hull Council, but also is going to be one of our partner governors in the local government role. I also met up with James Crick, who is the Public Health Director for Hull, and that was really great to be able to meet him and hear a bit more about his work and what his team are trying to address in terms of the challenges and supporting the community. Michelle and I and Lynn, actually, we met up with some people from Market Wheaton about some concerns about the primary care. You know that a lot of engagements happened on that front, and there have been some progress made, but it's always important to keep alive and keep people informed what's happening. I think we've got another meeting scheduled for after the summer. I think that's correct. Yes, I've got a thumbs up from Michelle. That's great. Joanne Bone at Town End Court, thank you so much. She was great to meet her and our other colleagues, including Dr. Michael, on a recent visit there, and I think some of my other NED colleagues have visited there too in recent times. I also attended the last BAME network meeting, and I know across the trust we take it really seriously around issues of abuse of our staff. It's a difficult situation that our staff can often face in very stressful situations, whether that's verbal or physical. We had a really good discussion about this at the last network, with several members of staff sharing some of their stories about what had happened to them. And in the context of this, abuse in any form is not acceptable. But obviously attached to this, was also racism involved as well. And I think it's just something I know we're very much alert to, and we have to keep alert to. But it was really important to hear from those staff members about their own experiences and how it manifests itself. And I know that's something we'll continue to listen to. Michelle, you're obviously the lead in this area. I know Hanif goes to the network as well. But it was a thoughtful meeting. It was a very thoughtful meeting. Just on the governor front, we recently had one of our revamped, what we're calling governor development days, although it was half a day. And part of what we've been doing is trying to enable more discussion, but also for my NED colleagues to be able to say more informally about the work they do. And my thanks. So this was the first one in the new format. Thanks to Stuart, thanks to Dean, thanks to Mike, who were there to talk about their work. We also had, thanks to Dr. Iqbal Hussain, who's the clinical lead for primary care. He did a really great presentation on our primary care services, and it was really illuminating. I think, people had questions, clarifying things, understanding. It was all worthwhile. And personally, as the chair, and I think my other NED colleagues felt as well, it was a worthwhile sort of opportunity for us too at that event. And we also had a session on health inequalities where, again, my colleagues in the public health directors of East Riding and Hull, who are amongst my new best friends, they provided me with some really helpful maps to show the sort of depth of poverty across the area that we represent, and how amongst a whole load of other things, poverty underlies so much health inequality in our communities. And so they helped me with some examples of that to share, and also to sort of flag up the NHS improvement programme, Core 20+5, and explaining what that meant to everybody concerned as well. So I think that was helpful too. And for anyone listening in who thinks, what on earth is that? The core are the sort of areas that the integrated care system, Humber, North Yorkshire, identify as particular for our areas. The 20 is looking at focusing on those 20% of our most deprived communities, and the 5 are some areas of clinical focus of nationally that the NHS has been able to look at. And I know we'll be talking about using that as a reference point going ahead. That's really all for me. I just want to say, and I'm thinking about how we do this. I know that some of our NEDs are doing visits as well, and it might be useful at some point to either have a log somewhere of those visits so people are aware of where we're going. And I have sought back some more information from NEDs on how we're going to do visits in the future, and that is a paper that I'll be putting together and obviously sharing with the board and governors too. So that's it from me. Any questions? No? Great. Chief Exec's report. Michelle.
Thanks, Chair. I will take it as read that people have had time to look at the paper. Obviously, I've been off for a couple of weeks, thanks to my colleagues, particularly Lynn. Just pull out a few things. I was obviously going to mention the Market Wheaton meeting. That was very positive. We've got a follow-up meeting, and I know that work is in hand in relationship to that. Going actually to a substantive report, there's no policies this month to ratify. It's great that you can see in there that there's lots of awards in there, from Humber Medical School to the Parliamentary Awards through to the Nursing Times, etc., across a vast array of our services. So very well done to everybody. And there's an additional one that's not in there because we only found out a couple of days ago, which is the Health Service Journal and Patient Safety Award, which we won one of those last year. We've been shortlisted this year again. So just shows you an array of fantastic services that our staff continue to do on the back of the challenges that we face and the demands in the services. So many thanks to those staff for making a difference, and everybody. But the menopause friendly one particularly is important. I know that the teams have done a lot of work on that, so it's really pleasing to see that. It goes on, there's a couple of things about the place developments with the integrated care system, and we've developed our own internal links now, which I think will be very helpful, so we can see how that materialises over the next few months, as obviously both the RCS develops alongside our own place people. And obviously, Michelle will come on to the communications piece, but there has been a lot of communications ongoing, and we've got the Health Stars report at the back alongside all my other colleagues to pick up. I will just pick out one thing in relationship to communication, that's the Miranda. We're having a bit of especially events at Miranda, please make sure people lateral flow test before you do go anywhere within our services. And that's for 25 years, and that's on the 15th of July. So we're just arranging the itinerary for that, and we will send that out. And we've got the 2 non-executive directors from the ICB coming to visit us on Monday. And that itinerary has been concluded. I'm not going to mention my challenge because it keeps reminding me it's tomorrow, but that's my annual challenge for Health Stars. And I'll stop there. I'm sure other colleagues want to come in, and we'll just add something that's not in the report because it's just been agreed and finalised. Obviously, it is sad to see John move on to pastures new. I'm sure we'll cover that later. But we are out to advert, and we're having quite a really good response actually, which is really positive. But in the meantime, we've appointed Dr. Michael Desiree as the interim medical director. Referred to as Dr. Michael. That's Dr. Michael's preferred name. So really great to welcome Dr. Michael back. Some of you may know Dr. Michael. He was the previous medical director, so he'll be working 3 to 4 days a week on the interim medical director alongside his clinical duties at Townend Court. I'll leave it there, Chair. I'm sure my colleagues may want to come in, but I'll pass it over to the board for comments.
Thank you very much. Any of the other directors like to come? Michelle?
I'll just pick up on the communications, if I may, Chair. The comms and marketing team continue to support teams to reach different audiences. Again, you'll see positive media engagement that continues, and the new spaces at Willoughby Hill, the office spaces, we're going to ensure they're branded and brought to life using the correct brand. And just finally, some members will remember some years ago we invested in Popolo, which is a software tool to allow us to target specific groups of staff, and that was to, one, reduce unnecessary email for other groups of staff, and to give us that targeted approach to staff groups that we really need messages to get through to. And you'll see from the performance stats that 65% is our current performance, which is twice the average rate for the healthcare sector. So we're doing really well with that. And just to back up what Michelle's just said in terms of how busy it is, we've got awards, involvements in awards, events, celebrations. So a lot going on, and it's not just about the comms team, it's about everybody across the trust who come together in order for us to communicate it. So ongoing work, but really positive. Thank you, Chair.
Thanks, Michelle. Lynn?
Yes, thank you, Chair. I just wanted to add a little to the context set out in the COVID part of Michelle's report. And Caroline, you mentioned it earlier anyway, just to say that not surprisingly, the processes are already in place for planning for this winter. So where we are now, obviously, as we have all as providers, assistant partners, reviewing our plans that we had in place for last winter and beginning the process of firming those plans for the coming winter too. Obviously, the expectation is this winter is going to be a challenge. Not that any winter isn't a challenge in recent times, but obviously likely to need to provide a autumn booster vaccination update programme for COVID, along with the flu vaccine programme, along with the other winter pressures. So just to add that. Also, in relation to the COVID update, just shows how quickly infection prevention and control guidance is changing. So there is a change actually that Hilary may well want to pick up on from what's written in the report around social distancing. But I'll let Hilary pick that up, but just to have that noted.
Okay, before I go to Francis, is there any other EMT member that wants to flag anything at this point? Hilary, do you want to pick up on that? I open up to questions.
Yeah, I had my hand up. I thought Lynn was covering.
Sorry, I didn't see it. Sorry.
It was just the COVID update, the social distancing and the mask wearing. That since the report was written, we've from today, in line with national guidance, masks no longer need to be worn in our services, and social distance doesn't have to be maintained. It's all on the back of doing risk assessments in your areas as well, but this is the national guidance trying to get healthcare providers back to pre-pandemic status. So obviously there's infection control procedures to still be followed. If you're looking after a patient that's got a transmissible infection, you would still be expected to wear masks, PPE, etc. But the general wearing has now ceased. Obviously we'll keep it under review, but it is a national requirement. National policy. It was for us to obviously decide how we interpreted that. So we've gone with the cessation, and we'll see how that plays out.
Thanks, Hilary. Francis.
It wasn't a question because the report, as ever, is detailed and comprehensive. It was really a comment to say it was good to see the ongoing development of partnership work with East Riding of Yorkshire on the adult mental health and with TUV. So 2 good examples of partnership working, which is good to see.
Thanks for that, Francis. I can't see any more hands up. So I think, as Francis said, comprehensive report. Thanks for those verbal updates to it as well. And we can move on to publications and highlights report. Michelle.
Thanks, Chair. As always, it's there for information. We've picked out, obviously, some of the ongoing work, a lot of it around the CQC, which we referred to earlier, and some of the innovations in general practice regulations are in there, and the integrated care boards. There is a paper later, thanks for Lynn for authoring it while I was away, about the messenger report. So that's a separate one that we'll pick out under item 12, but it's there for commentary or any observations, Chair.
Thanks so much, Michelle. Any questions or comments? No, so I think we can say that's received and noted. And we move on to performance report. Pete.
Thanks, Caroline. So this is the performance report, which takes us to the end of May. The eagle-eyed among you will notice that we've reintroduced incidence data into the report now, but we now report that as incidents per 10,000 contacts with further supporting information at divisional level. I guess in terms of this month's report, there are some areas of concern highlighted for the safer staffing dashboard, but there's detailed narrative within the body of the report. And I guess to keep it balanced, there's also the positive assurance to note on mandatory training and clinical supervision. We've included some narrative on waiting times in the body of the report, and if memory serves me correct, I think next month is the time we will bring the detailed appendix on waiting times, because that'll be the next quarterly update. So I think if I stop there, Caroline, I can see Hilary's got a hand up, and then we can move to questions.
Thanks, Pete. Hilary.
Thank you. So the safer staffing dashboard, I just wanted to say a few things on that. So that's on page 71 of the pack. The care hours per patient day have been entered in error for Granville Court, Whitby and Malton. We can't actually rag rate those because there's nothing, we can't benchmark against anything for those. So I think crept in this month by error, so I'm just making the board aware of that. In terms of clinical supervision, we've just got this month's details through, and new bridges are 79%. If you note, last month, April, they didn't send anything in. It was a no return from them. Pleasing to see, as usual, no reds in that end column. Lots of sickness, which is of a concern. But generally, the quality indicators are looking okay. That, you know, considering the sickness that we've got. I have spoken to Lynn about the sickness in our inpatient units because it's up persistently around the 12-13 units, flagging red. I looked back 12 months ago, so it was, you know, in the thick of COVID 12 months ago, and it was a lot less than that. It was about 8 that were flagging red. So there's something that we need to look at, I think, around sickness on our inpatient units and what's driving it. How much is COVID? How much is long-term sickness? And Lynn made a really good point that obviously, just like the rest of the population, sometimes struggling to get access to primary care, our staff are no different. If they've got a long-term condition, they've maybe not been accessing primary care. So just to really give the board a heads up that Lynn and I are just going to do a little bit of work on that and look at what's driving that sickness in our inpatient units.
Thanks for that, Hilary, and flagging that up. Thank you. Appreciate that. Anybody got a question or comment? Francis?
A couple. Hilary's picked up one of mine, which was on that. And it's interesting because within the report, it says that COVID illness has dropped quite dramatically. So that's other than COVID, a lot of that by the looks of it. So I'll await the outcome of that. On the cover sheet, just on some of the points that were pulled out, in terms of paediatric ASD, I was just wondering, we talked about a subcontractor failing. I just wondered, you know, how many suppliers are there out there? What is the market that we've got? On the memory diagnosis, just when great to see that we've got something in there, but when will it take impact? And then also on the early intervention in psychosis, again, to see the work there is great. So when will we get to a positive position? So it's 3 questions around that, really.
Thank you, Francis. Who'd like to pick that up? Lynn?
Yes, thank you, Francis. On the issue with paediatric ASD, we've already been out and tested the market for additional suppliers, and we have done a due diligence process in relation to one of them. So just going through the usual contractual process at the moment, but hopefully we will have a new supplier on board from the beginning of July. On the
many suppliers of that service, Lynn?
I think part of the issue, Francis, is actually it's a growing market at the moment. So actually one of the issues I think that's happening is those independent suppliers are competing with each other for staff at the moment, which is also unfortunately having an adverse impact on the availability of staff to the NHS. So market, not surprisingly, because we're not the only area who are challenged with increased demand. We had that anyway, but COVID has, the reasons we've discussed here many times over, worsened that position with its impact on children particularly. So it's a very difficult market at the moment.
Okay.
On your question about the memory assessment service and when that additional medical resource will be in place, it should be beginning to mid-July, Francis, so we're very optimistic about that. And the early intervention in psychosis service, as described, has been predicated on filling vacancies in that service, which we have do. Those will come on stream from sort of end of July onwards into September. So our recovery trajectory obviously is predicated on that recruitment having taken place.
Okay, thanks.
Thanks, Francis. Thanks, Lynn. Stuart?
Yeah, thank you. Lynn, that's a very interesting point you make about the supply side, because in other quarters we identify that there aren't enough suppliers. There's kind of limited choice, and it probably reminds us about the need for us to, where we can kind of not make the market necessarily, but certainly kind of influence the supply chain to behave in certain ways through our commissioning and procurement functions. So I want to follow that point up. I'm going to just raise something which I think I talked about last time, but I think it's important. The graph of the 52-week waiting list, which is on page 80 of the pack, we talked about it last time. We talked about it in the context of increasing numbers of referrals. That line is just persistently sort of creeping up and up. And I know there's work going on, and I know that Lynn and others are engaged on a very frequent basis on tackling. I think as a board, that's the one I think we need to kind of just really keep our eye on, and perhaps understand. I'd like to understand a bit more detail, not in this meeting, but beyond. What is it we can do to increase our capacity? We've talked about. We look at the risk register. The risk is we can't secure enough staff. We've just talked about with our previous presentations, haven't we? I'd really like to understand what is it in our capacity that we can seek to influence more easily than other elements to try and bring that line down. I don't need an answer to that now from the execs unless they want to, but I want to make sure that people understand who might be watching this that we're engaged on it.
Thanks, Stuart. Lynn?
Yeah, I think, and Stuart messaged me about that, and obviously that underpins all the work that we're doing at the moment, as you would expect, Stuart. I'm very happy to bring some of that, or as much as that would be possible, to the more detailed update next month, Chair, which will have, a deep dive into the waiting times. So I will describe some of the capacity demand analysis work, the approach that we take around that, and where that's leaving us at the moment in terms of our trajectories. So if you're happy with that, I'll put as much of that in that next update as I can.
Thanks, Stuart. And Lynn and I have also had a chat about, governors have been interested in this as well, and we've got a governor development session in September, and Lynn and I were talking about doing an update presentation there, which I think would be helpful too. Hilary.
Thanks. Sorry about it, because I was on leave when this report was finalised, so I didn't get to see the incident data and the way it was being shown. I do think we ought to show the percentage of harm-free care we readily have that information. It just gives some context, I think, to the numbers, you know, how many are actually harm-free. So it'd just be a simple little box to put in there. So it's ask BI to do that.
Yeah, that sounds a sensible idea. The context is important as well in all of this. Thank you, Hilary. Anybody else? I can't see anybody else. So thank you for the questions and for the answers and presentation. We'll move on to the finance report. Pete.
Thanks, Caroline. So this month's report is based on the ICS plan submission we were aware of last month, so it doesn't reflect the most recent planning update round. So for the avoidance of doubt, that was a planned deficit of just over £1 million for the financial year. At month 2, we recorded a deficit position consistent with that plan, which was namely a £275,000 deficit. Yes, the key points I would pull out from the report is agency spend continues to be above previous years and is definitely above the Trust's previous agency ceiling. And a review of agency spend has taken place at EMT, and a recovery plan is being developed by Lynn with support from myself. We've seen an increase in our cash position, and that is predominantly due to the payment mechanism for the lead provider contract, whereas in H2 of last year, we were paying monthly on predetermined blocks. Now we're on an invoice arrangement, lead provider to lead provider. So some of those invoices are a little bit slow coming through. And our better payment performance is strong for non-NHS, but less so for NHS. And we have done a little bit of a deep dive in that. And it's not because we're not paying people quickly. What we're finding is people are putting invoices that have been queried on hold in our SBS system. So we're just doing a bit of work to improve that and pushing some comms out on that. So I'll stop there for now. They were just some of the things I wanted to pull out. I'm happy to take any questions.
Thanks for that, Pete. Are there any questions from anybody? Francis.
Not so much a question, just a point that once it's been through EMT and gone through the right governance, primary care is coming through to FIC, and I'm sure agency costs will come through to FIC once it's been through EMT. So just from a governance perspective, some assurance there.
Thanks very much, Francis. That's good. I can't see anybody. Dean, sorry, Dean.
Yeah, thank you. It's just a reflection, really. Just thanks for the update on the finance, Peter, around the sort of agency spend. And I guess it's just that dilemma, isn't it, of when we've got constraints on things, it's pushing the toothpaste around the tube. So we've just been discussing about sort of struggling to recruit, and when we can't recruit, then we're reliant upon overtime or people doing extra hours or agency, and it's just keeping those things constantly in balance to sort of do that. So it's good that there's a plan coming together to look at the sort of agency spend, but sort of recognise also the operational problems that people are facing is that if you move one thing, something else can go up. So it's doing that in the sophisticated way that I know you're looking at things in that way as well.
Thank you.
Thank you, Dean. Okay, I can't see anybody else. So thank you. That's received and noted. So we move on now to item 11, analysis of Ethnicity Mental Health Act report. John, over to you.
Thanks, Chair. So this is the paper which was previously brought to the Mental Health Legislation Committee earlier in the year. And we've carried out this exercise, I think, 3 or 4 years in a row. Now, if I could just set the context, Chair, about race and how we think about it. Obviously, as an NHS institution, we have to think about how we treat citizens and service users from a perspective of race. And what this paper does in terms of some of the data is think about race in the perspective of service users. But as you've mentioned earlier on, in terms of how you attended the BAME network, we also have to think about race in terms of how, as an institution, we treat our colleagues that work with us. We also have to think as an institution how colleagues who work amongst us treat each other with regard to race. And then finally, just as importantly, we have to think about how patients and service users treat our colleagues who might be from an ethnic minority background. So race is nuanced, it's complex, it's not just about services that provide and things that we do unto people. It's a little bit deeper than that. Now, there is a wider national context. I think finally society is deciding to accept the fact that we have challenges with race and ethnicity in the country and the exclusion that leads to. And it's positive to see reforms that have now been talked about more openly and perhaps in a less hostile way than might have been the case. And that's perhaps more important than ever, bearing in mind the social situation we currently find ourselves in. So I just want to refer board back to the work that the Care Quality Commission have been talking about in terms of closed cultures, because ultimately when we think about how we look after all citizens, including people from a minority ethnic background, is that fits under the work of closed cultures. So in other words, how we detain people or not, and how we actually provide services to them. There is also the Use of Force Act, which is otherwise known as Sena's Law, which we have talked about in the organisation, has come through the Mental Health Legislation Committee and has also been referenced to board. That's an important piece of work just to remember in this context. And also we will have changes to the Mental Health Act coming down over the next few years. So all in all, there is a lot of work going on with regard to how the NHS thinks about race, how it thinks about equalities and such matters. But frankly, there's a lot of work still to do because we certainly do have challenges. Now, what does it mean in terms of Humber? Well, as I said, for 3 or 4 years, we have been looking at this data. In many ways, we know when we look at national data, there is a significant challenge there that people from a minority ethnic backgrounds are more likely to be detained under the Mental Health Act than people who from a white background. And that's clear cut. There's no discussion about that information. So the question for us is, when we look at our data set, actually, does that translate into what we see? Now, what I would say is that we have a small data set. There are challenges with regard to how we benchmark our data based on Hull and East Riding population data. There's a slight challenge in terms of how we record the ethnicity, and that's one of the improvement pieces that we need to do as an organisation going forward, and that's already in hand. And then we're left the case where we have small numbers, and actually sometimes small numbers can increase the risk of either complacency, or likewise they introduce the risk of bias because you've got small numbers. But what the numbers would suggest is that there isn't necessarily we're not significant outliers in terms of how the Mental Health Act is applied with regard to minority groups. Now, most people might think of minority groups, particularly with regard to colour. However, what we've said in this report is we've highlighted that this is an area where we have lots of Eastern European citizens who have moved to sort of Humber, East Riding, North East Lincolnshire. And perhaps these are just all chucked in as being white people, and perhaps that we need to understand an awful lot more about the actual origins of people right across the groups, just to make sure that when it comes to detaining and the use of the powers that we have, that all groups are not necessarily being detained unnecessarily, not just particularly from an ethnic minority group. So it's a complex piece of work which is underway, and we need to improve the data. I am satisfied that when it comes to education and training, particularly with regard to doctors, that this is being addressed through core curriculums at undergraduate and postgraduate levels. But we do take this data back into the medical networks to talk about it and consider it in a little bit more detail. I suppose one of the protective factors we've got is that our actual medical body, who are empowered with these powers under the Act, are actually probably the most diverse group of professionals that we have in the organisation, which in itself theoretically could be a protective factor, but I certainly wouldn't be complacent about that. And just to reference the fact that Steve and Hilary are leading on other pieces of work with regard to race, which I pointed out relates to how staff treat each other, how we as an organisation deal fairly with staff, but just as importantly, how we react when our colleagues who work in the organisation are subject to race issues because of the nature of their backgrounds. So the data is the data. As I said, it is small numbers. And we've also included the minutes of the Mental Health Legislation Committee where it was discussed more in detail. I think, there might be an argument for next year that actually this report comes straight to the full board as opposed to coming necessarily through committee. There's an argument for that. Bearing in mind, Chair, your comments that your new best friends are your public health colleagues, James Crick and stuff, when it comes to how we think about health inequalities, it might be actually that we just need to think about our data using some external expertise so that we're not necessarily subject to the bias that might be from John, the medical director. However, when I think about the ethnicity data, I would just say that, Irish people, when they first immigrated to London, were from a certain social background and were disproportionately represented in mental health services in North London, had dual diagnosis, particularly because alcohol problems are rife as part of Irish society. And that might have been a problem in the 60s and 70s for Irish citizens. So I could just say to people that I do understand from an ethnicity point of view, particularly when we think about Eastern European citizens who have happily lived amongst us for a long period of time. It's just important that we don't find ourselves reading reports in 10 or 20 years' time that we weren't paying attention to their needs as well.
Thank you, John. My group of best friends is growing by the day. Mainly it's the support for people who know more than I do on things, I have to say. I thank you for that. It's really good. I thought it's very interesting in the over 16, the sort of before we get to next steps on the report, that you mentioned how it shows people from ethnic minorities not choosing to use our services voluntarily. I thought that was a really interesting takeaway from some of this as well, as much as the local white population. So
and the danger of that, Caroline, it might be an assumption.
Okay.
It's possibly true. So, I wouldn't necessarily say it's not true. But let's say Kwame, our clinical director, very experienced consultant psychiatrist, feels that's the case, which is why we get later presentation from people from an ethnic minority group, which might be disproportionate in terms of the Use of Force Act. Now, that's a plausible explanation, but I wouldn't necessarily personally take comfort in that, because it still means that in terms of health inequalities, there's an accessibility challenge there, which in our case may not be so much about, more about colour, but actually might be from where you come in Europe, basically.
Yeah, totally. Whatever reason, it's sort of using this to look a little bit more, isn't it, at what's going on. Thanks, John. I've got Mike and then Stuart and Hanif in that order on my list. Mike.
Thanks very much, Caroline. Thanks, John. Really pleased that this has come to the board, and I agree with your suggestion, John. Cut out the middleman. It's a board issue. It doesn't have to come to mental health legislation first. In relation to access to services, yeah, I'm not a clinician, but I see a lot of patients with my other roles. And there is this temptation sometimes for mental health problems to be kept within the family. It's not an excuse. But I think it is there. I think your clinicians are right. In terms of statistics and data, we're not helped by the small numbers, but we are trying. We're in a much better place than we were 4 years ago in terms of our understanding. The only thing that I wanted to add into the pot, though, was that I'm now starting to see a connection between this work and the health inequalities. And I'm starting to wonder, flying a kite, whether the health inequalities statistics in terms of detentions is potentially more important than the ethnicity.
John, thank you.
Yes, Mike, it's a good question. I suppose we could think about how we looked at it through the deciles. So in terms of our tensions, my gut instinct, Mike, would be that the people who I'm not sure. It'd be interesting to see. I guess that actually, in terms of deciles, which is when I talk about deciles, I mean deprivation, that actually we will see a link between deprivation and admissions. But whether there's an adverse findings in terms of you're more likely to be sectioned if you're from a lower socio-economic group than the higher ones would be an interesting question to ask. And I'd hesitate to throw out a guess or an assumption around that one, Mike. But it's certainly something we can look at as part of the package, because it's a fair question.
Thanks, John. I think making the connections and seeing this as part of that wider health inequality agenda, I think is really important, because poverty is such an underlying factor, isn't it, with other things. Okay, next up is Stuart.
I was going to want to make exactly the same point. The data, I found the data really fascinating, by the way. And in terms of sample size, apart from the ones on the right-hand columns of the pages, the samples are probably statistically, valid. I think the inquiry should be, well, if the white non-white category doesn't really shed a light on much, and it doesn't seem to shed a light on much, let's get some, let loose some statisticians on the data. Say, so what are the underrepresented or the overrepresented characteristics, whatever they might be, and it might not be ethnicity, it might be poverty, or it might be experience or something else, but it's really just the data is there to be understood, isn't it? And while it was interesting, it left me thinking actually we might be asking the wrong question on this paper. There's probably another set of questions, and I think that the work we did was it last week wasn't on health inequalities. So essentially, a geographical locational analysis might tell us a bit more, for example. So yeah, interesting, really interesting data.
So it's interesting data, and there is something about we can torture the data, so to speak, Stuart. And part of me thinks with my holistic head on that really the real win that we will see going forward is talking about it like we're here now, but actually equipping our colleagues at all levels throughout the organisation with the skills to make sure that we don't go down any rabbit holes or fall into any traps when it comes to equality and diversity. You know, and that's not just about statutory and mandatory training, although it does play a role, because when I think it comes to think about how doctors behave when they see patients or nurses behave, I think that's more ingrained professional stuff, which takes a period of time to develop. But and you know, I know that our director of medical education is keen, as is the you know the Royal College rep, that we start to do a little bit more of that sort of work, and particularly with our medical colleagues. But I think there's a wider opportunity beyond medics with regard to that.
Yeah, thanks.
Thank you, Stuart. Thank you, John. Hanif.
Thank you, John, and thank you for the frankness of the presentation. You alluded to the fact that while the trajectory is right, there's still a lot to do. I'm just wondering what that a lot to do actually looks like, but more importantly, where it's articulated within the organisation's strategy moving forward in terms of who picks it up, particularly with you moving on.
So a couple of thoughts there on the data, isn't it? You can have, I'm not sure if we had low numbers of admissions and low percentages, whether that would mean that people are missing out on care. Although perhaps there is something, as Kwame has pointed out, thinking about emergency presentations as being an example of how people don't get to access services. And actually therein lies the health inequalities for something to think about. The education piece is certainly going to be picked up by the Director of Medical Education, Soraya, going forward. But I think we just need to think of this about a broader suite of intelligence and data, Hanif, because there is not one perfect data set for this, to be honest with you. And I know people like to think there is, but you know, I think it's important that we look at the data, we consider it, but we don't necessarily use the data to say we're okay, nothing to see here, move on when we know society is a problem. Likewise, I wouldn't necessarily want us to start beating ourselves up for something which isn't necessarily an issue either, because of the data and how we've presented it. So, you know, the interim medical director coming in, it'll continue to sit with them. The mental health legislation, where we cover this off on an annual basis, and will continue to sit under the medical director. But, you know, I have to say, as an organisation, we started looking at this 3 or 4 years ago and thinking about it. Not an awful lot has changed, I have to say, Hanif, in terms of our data over 3 to 4 years. I don't know whether that's a good thing or it's a bad thing, but nevertheless, we're starting to build up a data set going back 3 or 4 years, which means that we have been thinking about this. I suppose the question is, and perhaps where there's some external scrutiny might be useful, is actually, are we missing something here and we just blindly staring at data and either being biased or complacent about it in equal measures? And I have to say, it's beyond my expertise necessarily to give a definitive answer with that particular question in mind.
Thanks, John. Thanks, Hanif. Michelle.
Yeah, thanks. It's good to see this here, and obviously, as always, and as it's developed over the last couple of years, so I think it's really helpful. I think it asks more questions than it answers, which is great, because that's always the start of the conversation. I think that's what we're discussing today, and how we link it into some of our other work around population health inequality. So what I was going to suggest is that we just get AMT to maybe have a look at this and have a look at the data sets, the data collection, so that we can start to develop it further. Would be my suggestion, because it's a good moment in time. But what is the art of the possible with it? Because it's part of the tool set that we need to be able to talk about health inequalities and the work that we're doing in relationship to that and diversity. So if that's okay with the board, I would suggest that.
I can't see anybody suggesting they don't want that. Thumbs are going up. So I think that is, we can take that forward. That would be really helpful. And also add in, obviously, that which there seems to be agreement on as well, that the paper should come direct to board next time. Brilliant. Thank you so much, everybody. That's great. Let's move on then to Michelle, leadership for a collaborative and inclusive future, please. Item number 12.
I'm going to pass over to Lynn actually, because in my absence,
sorry.
you wrote a far better paper than I probably would have constructed. I did want this to come here because it's obviously the messenger report, which is all around leadership. If you remember, Dame Linda Pollard and Gordon Messenger did a piece about leadership. So I just thought it was useful for us to have some conversation here, and then maybe just support the workforce committee, who I'm sure with EMT and OGG will lead some of this work forward. So Lynn, do you mind just picking it up for me, please?
Yes, thank you. I'm going to assume people have read the report, and then people may well have read the full report as well. So hopefully this is a reasonably comprehensive, as Michelle requested, description of the content of the report. So as described by Michelle, Gordon Messenger and Dame Linda Pollard were asked by the Secretary of State to have a top to bottom, bottom to top review of leadership across health and social care. So, and that in terms of methodology is set out as well. Primarily the methodology was really around feedback from a broad breadth of staff across those areas. And it's concluded, as you can see, in 7 key recommendations. I guess out of those recommendations, I think the first one that really sort of struck me was the recommendation particularly around training and development being standardised across the NHS and social care, and some descriptions of how that will happen at entry level and at mid-career level. I thought what was interesting, I think that certainly resonates for me with conversations that we've had in our board as well, that generally those trusts, providers, organisations that engage with positively the EDI agenda generally were perceived as having effective or more effective leadership than those that don't. So I think, again, that's something for us to continue to consider, which I'm sure we will going forward as well. Obviously, it comments on appraisals, particularly. I'd like to think that some of the findings in relation to appraisals have been part of the conversations we've had indeed around our own approach there. And then sort of more broadly, recommendations around career and talent management going forward. So the expectation is that these recommendations are going to be taken forward in a detailed implementation plan, which will be announced. It's expected in the relatively near future. But I guess for me as well, the fundamental bit, which I guess no surprise really, is the need for that focus on collaborative leadership, which we've talked about today as well, underpinning, the intentions across the health and social care sector going forward, and that collaborative leadership needs to be underpinned by access to training and development. So I'll pause there. Michelle, I hope that sort of covers the breadth of the report for you, but I do think there's issues within this that, certainly are worthy of our consideration.
Thank you, Lynn. Any questions or comments on this? Dean.
Yeah, thanks, Lynn. I thought it was a really helpful summary that you've got in there from the report itself. Just a couple of observations to add, I suppose. I mean, it was a report across health and social care, and it was light, I think, in terms of primary care and social care. And I think some of the recommendations seem to be channeled through the focus of secondary care and, larger organisations. And I think as an action plan develops, there's an opportunity for us to be suggesting maybe about what does that mean in areas like primary care, if you look at things like common appraisal systems and training and development, for example, as well as sort of social care in that. And then the other thing is, I suppose it's just being alert to, isn't it, that sometimes I think good leadership can be presented as a Shangri-La to all problems, and we know that there are systemic problems in parts of the NHS, and in my experience I think we've got some fantastic leaders in some very challenged organisations, and it's some of the systemic issues I think that need addressing perhaps rather than leadership. And I think it's important, isn't it, when we look at organisations that are struggling, is not always just to point the finger at the leaders in those organisations if there's something more going on. I'm minded that we are far more understanding, for example, in schools, where we'll talk about head teachers having achieved what they've achieved with what they had. did they achieve more rather than in perhaps some more affluent areas, for example? So there's something there. And then just finally, there's just something about the equality and diversity, again, given the conversation we just had, that seemed a little bit light. It talked about having that included, everybody's business. But again, I think we really need to get into what is it different that we need to do, and how will that get sort of traction in the organisation. But I thought that was a great summary report in there, and it will now no doubt translate into action plans, which we can no doubt influence and contribute to, and then see how we deliver on the ground. But thank you for that.
Thank you, Dean. Michelle?
Yeah, I suppose obviously that Dean said, and I think for me it's more than developing that action plan. It's how can we take this report, which is why I wanted it to come to the board direct. How can we take this, and maybe that's where the workforce committee and others come in, and use it to support some of our leadership programmes, and whether we get a group of staff together to look at how we use some of the things in here, just a bit of a sense check. So that might be something that maybe Steve and EMT want to maybe have a look at, because there's some useful things in there, I think, that we need to seize the opportunity and also influence the ICS as well and their people agenda.
Thanks, Michelle. Listening to the conversation, it's probably quite helpful if, against the recommendations, we can sort of have a view of our trust on it and maybe see where there's areas that, some things are not within our control if they're going to have a national training system, but we might want to input something about our views on that. But some of the areas would be, benchmarking what we're already doing against what their expectations are. Probably another good item for a development session at a board timeout. Okay, thank you very much, Lynn. Thank you, Michelle, for that. Now, I know Colette's here, but Hanif has to leave early, and I know we wanted to do the equality delivery system. So if Colette can just hold, so we can pull up the equality delivery system report and deal with that first, if that's okay with everyone. Yeah, I hope that's all right with Colette, who's here for quality accounts. Okay, so if we go to the equality delivery system, Steve.
Pat, page 283, if it helps.
Sorry?
Pat, page 283, if it helps.
Oh, thank you.
Thanks, Caroline. So it's a jointly produced report with John and his team. Went through to EMT for consideration last week. So EDS2, something that we bring and have done for a number of years now, part of the NHS contract. It's a self-assessment. This is the self-assessment scoring that we've put together and is presented back to the board today. Unfortunately, because of timings, it hasn't been able to get to workforce committee or quality committee, and so that's just I guess by the way the committee structure falls, but presented for information on that self-assessment for submission.
Okay, thank you very much, Steve. Hanif.
Sorry, thank you, Steve. Yeah, I had two questions, one of which you've actually alluded to about has it gone to workforce committee in particular. But what I'm really interested in is the criteria, how we arrive at that self-assessment. So what the benchmark is in terms of making the distinction between achieving, excelling, working towards, and who's involved in that process. Is that just the EMT, or how, as I said, can you just elaborate upon that for me?
So I'll let John pick up for his side, but certainly the subgroups, both the two leads, so Mandy Dawley and John Duncan as our leads in the organisation, will consult on that as part with the EDI group, with the patients group. It comes through into EMT. So EMT will effectively sign it off, Hanny, but there's been a number of people that have played into that. With regards to what the scoring is, I mean, it's not an exact science. It is something where there's some guidance around there, and we try and choose a best fit. So, of course, for you may get some debate around the margins, but we try and fit our scoring against the criteria that's been set. John, anything that you wanted to just pick up on that? I know Mandy uses the group, doesn't she, for...
She does, and I have to say I kind of rely on Mandy and John, who are renowned for their independence, Hanif, and critical thinking. I think it is what it is. You can either look at the tick box and saying we're achieving, excelling, or actually you could just look at some of the punctuated narrative which demonstrates some of the things that we're doing. So I hate the tick box exercise element of this. It's an element of that. However, there is some information which is captured in that which might support a rating. But ultimately, we bring a whole swathe of information to public board talking about the work that we do around these agendas, whether it's the annual or 6-monthly patient care experience reports, research reports, and likewise the staff survey data that Steve will bring, amongst the other suite of data. So in some ways, it's distilling that down. You pay your money, you take your choice. But I would, it's like anything else with any data. I say no organisation is perfect, but I think because of some of the stuff that we've done over the past 4 to 5 years, we're in a better position than perhaps we might have been 4 or 5 years ago.
And just if I can just follow up, Chair, on that, John, does it then get cascaded back to the people who've had that initial input through either EDI or those patients' forums once we've come to that assessment for feedback?
A good question. I can't answer that, Hanif, but I'm sure we were happy to share it with them. But ultimately, the judgments on this paperwork are, dare I say, created by John Duncan and Mandy Dawley. We do not sit around an exec and mark our own homework. This is what they present us with, is based on their professional opinion, based on the work that they've done.
Okay, I mean, as Caroline said in her chair's report, there's some wider work going on. I'm happy for Workforce and Dean to look at it and say that future. Thank you, John. Thank you, Steve.
Thank you. Maybe we should have Mandy Dawley and the new person coming in to take over from John Duncan to explain a bit more about all of this at a future date, how it all comes together and is arrived at. Michelle.
Yeah, I was going to suggest that because I think we obviously need to get the timing right as well. But it was a big document that needed obviously board to see before we submitted it. I wasn't at EMT, and obviously there are a couple of things, but I'll leave them for now. But one of them just wanted somebody could explain to me. And as I say, apologies, I wasn't at EMT, and I did have a look last night, but it was too late to send an email out. It was 3.2, which is around the NHS's committee to equal pay. Given the fact that we're achieving and excelling in nearly all of them, and excelling in all of them apart from maybe the one, I just wondered what the narrative was around developing NHS's committee to equal pay. I've seen the job evaluation, I've seen the evidence drawn up for rating. I just didn't understand the two. I couldn't put the two together. So I don't know, Steve. I presume that's
well, we don't. So we don't do equal pay audits across the trust as it stands at the moment. That's the reason why it's got the score that it has. So something about whether we would want that's something we would want to look at in the future. Albeit that we've got a job evaluation system and everything there. If you took it from the letter, we haven't got the equal pay. We don't do equal pay audits as a separate piece of work.
So can we just put that there then? Because I didn't explain it. Because we've put evidence for during the rating, which were all positive, and there wasn't a counteractive one in there. I think we just need to add that. Apologies if it's just because I'm on my iPad and it's there, Steve.
Thanks, Michelle. Dean.
No, it's just to say, Michelle, I picked up the same point with Stephen Lynn on the sort of equal pay stuff, and I guess in a sort of reassuring for other board colleagues, work of equal pay for work of equal value is a sort of legal requirement for us to achieve. So it's different to the pay gap within an organisation, for example. And we use Agenda for Change, which is a nationally job evaluated system that means that we pay equal pay for work of equal value. And I was reassured from Steve as well that the rating on this one really relates to the sort of pay audit issues, and it's maybe something we can pick up within the sort of organisation, if in terms of getting there. But the reassurance bit is in terms of the pay system that we use does provide that equal pay for work of equal value, and then some audit will give us some additional sort of assurance about that. So I was happy with that explanation from Steve.
Thanks, Steve. I think we just need to maybe pick that up because it's the only one that's developing. So it stands out because obviously it's one of our mandates. So thank you for that narrative.
Okay, thank you, Dean. Thanks for that. I mean, I echo some of what Hanif said. I mean, I think it was quite hard looking at this document. It could be just the template the NHS have created that denies us the opportunity to explore some of these further. But I was a bit nonplussed about how we arrived at our ratings and the process for that and the assurance on that. And also, I know in the boxes, it's things we're doing. It then doesn't tell us, well, what happened? What's the result of all that? Now, that might be somewhere else in other information and other reports, but it's how we sort of triangulate this together to get that whole picture, it seems to me. And, you know, I think we flagged that up, haven't we, about how we might do that. And we mentioned it in relation to the earlier item around the ethnic minority issue in regard to the Mental Health Act. Okay, no other questions on that. Thank you very much. So, Colette, I really apologise for keeping you waiting, but thank you for waiting. And we go on to the quality accounts. And Hilary, I think you're going to introduce.
Yeah, thank you, Caroline. So I've got the quality accounts here. The quality accounts are required to be produced by all NHS providers. It was a requirement that came in after the mid-staffs inquiry a number of years ago. So these are our annual accounts, which Colette and Sue Hutchcroft have pulled together. As you can see, no mean feat. There's a lot of information in there. All of the things we've done around quality over the past 12 months is showcased in these accounts, which we then have to put out into the public domain. They've been to EMT and been signed off with EMT and the Quality Committee, pending the Q4 data that needed to come into them. I don't know if it's just my copy, but the index doesn't seem to be right. I don't know about other people's. I don't know if it's just not put. It looks like it's, instead of listing the index and what's at what page, it looks like it's tried to actually pull the information through there. So if it's the same with everybody's and not just mine, the report sort of starts proper on page 135 of the pack. But I'm going to hand over to Colette. I know she's got a couple of elements of information that weren't in the report because we didn't have them at the time, which is around the DSP toolkit, the Information Governance Data Security and Protection Audit. So we've got that, and we've also got the Q4 incident data as well, which I'll hand over to Colette, and if Colette wants to say anything more about the accounts. Okay.
Thanks. Hi, everybody. Now, sorry, I realise you're all working from a pack, so the page numbers that I'm going to use won't make any sense at all. But the first piece of information that we didn't have when we sent them out was around the Data Security and Protection toolkit, which we've now got back, and we've got risk rating of moderate and assurance level of high for that one. And the other piece of information, as Hilary said, was down. So in the actual documents on page 59 was Q4 incident data, which is in line with the rest of the year. I don't know if you want me to. I'll just run through the actual numbers. So in Q4 there was 1,698 incidents, of which 13 were of severe or death, and there was 3 new SIs declared. And I think today we're just looking for approval for the quality accounts, which have to be submitted at the end of June. And it was just if anybody had anything specific, it was just say that they're a bit of a mammoth document for me to go through piece by piece. And I think most people have seen them. So it's just if anybody had any questions or anything, any clarification.
What's the top line on it, Colette?
Fantastic work. I think it just highlights the fantastic work that's gone on in the organisation around quality, regardless of, you know, in spite of the years that we've had, and just things just continue to go from strength to strength.
And that's reflected in the stakeholder comments, which we have to put in verbatim at the end of the report. They're very, very positive, aren't they? Which they're not always, but the set that we've got back from our stakeholders are very positive about the trust and what it's achieved in the last 12 months.
Any questions? Any comments? Stuart.
Couple of an observation actually about this report that sits alongside the annual report and accounts, which we'll come into later. I think that together they provide a sort of the public domain story of the year just completed. So that's really helpful for me to kind of, that only sort of clicked in my mind during the last week. Very helpful. On the question of the story it tells, to what extent is it kind of independently kind of assured or audited in any way, or you know, verified?
Shall I pick that one up, Colette?
Yeah.
So previous to COVID, we had to have them audited, but since we've had the pandemic, we have been told that we can stand that down, so they haven't actually been audited for the last 2 years.
So it's our story, it's our self-assessment.
Our information based
and
on
just,
our information,
what would be how would you describe the spirit within which you wrote the report, ranging from everything, we're very skeptical, very hard on ourselves, to euphoria about how brilliant we are. What's our kind of tenor of editing going on there?
I mean, I think it's quite sort of factual. Do you know, I mean, although I sort of pull the report together, it's everybody in the organisation inputs into this report, and a lot of it's already picked up in other annual reports. And I think I do think when this report is a chance for people to be proud of the work that they've done, and a chance to sort of blow your own trumpet, but within the realms of being factual.
There's lots of confirm and challenge against all of the data, in not just other reports, but in other meetings as well throughout the year. It doesn't just suddenly appear at the end of the year, throughout the, including the board, and obviously the subcommittees. There's lots of confirm and challenge.
Thank you.
Can I just mention that I think on this, and this isn't taken away from any of the thunder of obviously the positive report, but in terms of engagement, I think Governor's got a wad paper quite late in the day in terms of a time gap to actually respond on. So I think it might be for next year to just think about how that's handled, in particular, in sending it individually to governors. Is from what I understand, some of those governors understand the context of what you're asking them to provide.
And in previous years, we would always have gone to a meeting with that. It's just the timescales were out of our hands this year. They came out very late.
I just think there's two things there, Colette. One is what is the cover sheet say, so they can be helped to not feel that they're suddenly getting a massive document to sort of comment on. It's a bit overwhelming, to say the least, and they're not sure about what they're meant to do. And I take your point about restrictions, but I think again, planning in time wise to do either a virtual or in-person event, or looking at our schedule for governor development sessions coming up to fit into having a bit of a conversation, even an early conversation that can be incorporated rather than seeing the final document and then asking for comments. That might be helpful.
Yeah, certainly take that on board, Caroline. We'll get something scheduled for next year.
Yeah. Thanks very much. Great. Thank you, Colette, for you and your team for all your hard work in this. I mean, one of the things about these reports and the annual report, we can pick out of it and pull together what is the story about what we're doing in the trust and our challenges as well as our successes. So these are useful aid memoirs to remind us all about the totality of our story. So thank you, Colette, for all of that. And I think we have to approve that here. So unless I see any objections, and I don't, that's got our approval. So thank you very much. Thanks, Colette, and thanks for waiting.
Thank you very much. Bye.
Cheers. Okay, then. So we now go on to the fit and proper persons regulation and trust compliance. As you all know, we have to meet certain standards in terms of what we do and how we make sure that we maintain records of individuals and their fitness for service and their activities. Jenny, of course, thank you so much. Jenny Jones, who's done a lot of the background work and making sure this is all put together. We are all in order. So unless there's any questions or comments, good. So we can receive and note that. Thank you very much, colleagues. And we move on now to board assurance, Oliver. And Oliver, are you going to do the board assurance and risk register together, or do you want to sort of talk to them separately? Or
sorry, Caroline, have you missed number 14?
Oh, 14 was going to number 18. We swapped that round because if you remember, we just shifted that around. I haven't forgotten it. I haven't done that. Oliver.
Thanks, Caroline. I don't know if Michelle and Hilary want to do their introductions separately. I'm happy to talk to both, obviously here for both items, so defer to them.
Great. Michelle, Hilary, would you like to say anything?
No, I'll just pass over to Oliver. Just obviously, as I normally do at this stage, I think it's been around the various committees and a lot of people have been involved in developing it to this stage. So I will pass over to Oliver to take you through it and then open to comment.
Thank you, Michelle. So with regards to the board assurance framework, obviously the version of the document that's come today represents the final version for Q1 of 22-23. So obviously considering that obviously the new financial year, this is the first iteration. As Michelle has highlighted, it's been through the board subcommittees as a working version in quarter, and it's also been through Operations Delivery Group and EMT as well for sort of final sign-off. I think the main points for that, in terms of the overall assurance ratings, they have remained the same from previous quarter coming into Q1. However, obviously all of the assurance sections have been updated as required with the relevant exec leads, and obviously subsequent information incorporated as well where required. I think the main area of change on the document, just to highlight, is probably strategic goal 5 around the financial elements. Obviously we've made some changes to the financial risks that sit on the trust-wide risk register, which we'll come on to on that document. So that's referenced on the BAF section, and obviously then the updated financial information for the quarter has been incorporated as well, just to show current position as recent as we can get it. So that's probably all I'd look to do in terms of introduction. Obviously, as ever, it does represent the final version, but any comments or any queries that we can consider taking into the next quarter, obviously we'll start the process of developing the version for Q2, which should be coming to the board, I believe, in September. So obviously we're working towards that and going through the board subcommittee. So if there's any questions, queries at this stage, please.
Francis.
Yeah, just a couple of minor ones from me. So on pack page 272, which is developing an effective empowered workforce, it's just struck me over the last week or so, in terms of negative insurance, with what's been going on recently with sickness levels, I don't know whether that needs to be included with them being as high as they are. Just a thought. And then on pack page 273, in terms of positive assurance on maximising efficient and sustainable organisation, just a question, and Pete can comment, should we not put in the fact that we've delivered our control total for the last 4 or 5 years? You know, we are a consistently performing trust. And then on the negative assurance, I'm not sure I understand what it means. Recurrent pick of non-recurrent resources is not known at this time. I'm not sure I understand that.
So do you want me to come on goal 5? I don't think that reflects the last one we did, Francis. That should say non-recurrent items have been used to balance the financial plan, which we talked about earlier. So apologies, I don't know if it's just got lost in transition, Oliver, but we updated that one. What we're trying to get across there, Francis, is we're using non-recurrent items to balance the financial plan.
Right.
So that's the gap in assurance, which we talked about earlier when we talked about the financial plan. And we could include we've delivered it, but I guess because we delivered it in previous years, if we've got risk for this year, what level of assurance does that really give you? I mean, you know, personally, that's been and gone, hasn't it? We've got a good track record, but we know we're going into choppy waters.
I just think in terms of assurance, Pete, the fact that we consistently deliver is kind of, you know, shows how well we control our plan. Anyway, I'm not going to die in a ditch on it. Just thought it was an interesting one.
Yeah, well, I bow to the board. I mean, like yourself, I don't die in the ditch on those things.
Okay. Any other questions or comments? No. Okay. Oliver, is there anything else you want to add?
Not for the BAF, but I suppose thanks, Francis, for the comments. We'll make sure those are we'll take those away and obviously consider them as part of the Q2, particularly around the sickness levels as well. Obviously, we're working towards a data set previous in quarter, so obviously that will hopefully be reflected on the next version as we bring through the up-to-date data for Q2. And obviously I'll pick up the finance elements with Pete and we can see how we're going to address those going forward ahead of it next coming to Finance Committee.
Thanks very much, Oliver. Do you want to go on to then the risk register update?
Certainly.
Hilary, did you want to say anything before Oliver begins on that?
No, I think I just hand straight over to Oliver for it.
Okay,
Brilliant.
thank you.
Thanks, Hilary. So in terms of the trust-wide risk register pack that's come today, obviously represents the current risks which have been scored with a current rating of 15 or above, so red-rated risks for the organisation, and obviously been approved at that score via EMT. In terms of composition, the main sort of changes to highlight are around sort of the finance risk. So previous entry FII 205, which was the longest-standing financial position risk that we had on there for some years, has now been retired and replaced replaced with 2 additional entries, one of which has been scored and included on the document, which obviously represents financial position, but in sight of agency spend as well. The 3 workforce-related risks carry over from the previous quarter, so that's WFO3, which is around nurse recruitment, WFO4, the nurse retention position for the trust, and then WF10, which is around the recruitment and retention of GPs. The 2 operational face risks, again, carry over from previous quarter as well. We have a look at those, and obviously there was some discussion of whether or not we were in a position to bring either of those down. It was felt for the quarter's position we would maintain them at their current score, but obviously then going into quarter 2, we'll take a view on each of those risks again and consider if there's any changes to the scoring. So those are the main elements to capture. In terms of sort of the overarching position for the risk register, which is included as an update as well for total numbers across the trust risk registers. There was a slight reduction from 174, an increase, apologies, from 169 to 174. So across the board, only an increase of 5. Obviously, beneath that, there is some sort of changes between the divisional registers and direct risk registers that obviously gets to that level. But in terms of overarching composition, nothing drastic to highlight. There's not a particular area that is adding a massive number of risks or vice versa, taking a number off. It seems to be fairly sort of interchangeable in terms of individual numbers of risks that change between different areas. Obviously, we continue to take the risk registers through operational delivery group from a divisional perspective, and obviously then we incorporate relevant risks to the relevant subcommittees, whether that's quality risks to quality committee, obviously finance related risks and workforce related risks to the relevant board committees as well. So again, happy to take any comments on the risks that currently make up the document, anything we need to consider going into quarter 2, or anything that perhaps following discussions today that we feel is perhaps missing from the register as well would be useful to hear.
Thank you, Oliver. Any comments or questions to Oliver? Francis?
Sorry, I keep putting my hand up. Just on the, what would be helpful for me if the board are happy to do it, is on the trust-wide risk register, to have the date that the initial risk was scored at 20 and have the date that the risk moved to 15, because some of those initial risk scores, I think, go back quite a long time. They're not initial risk scores from the start of this year. They were set up, whereas some of them are new. So it would be useful to know when it was set up originally and when it changed. It's just my view. I don't know what the rest of the board think.
Sounds
the initial risk score is on there, isn't it?
Yeah, the initial score will be linked to the open date, Francis.
Yeah,
we keep the initial score fixed, so we don't tend to make changes. So you'll have that date, and then I think with regards to, obviously we can have a look at the dates that the changes were made to the current score, and that's absolutely fine. So we can highlight that on there. But in terms of that initial score, that is there as the risk open date, and that will be the date where the sort of that rating was decided initially, because obviously it doesn't change from that point. We don't rebrand that.
That's great. If I could have the date on it, it would just be useful to know how long ago it came on, so to speak.
Yeah. Okay. Thank you. Stuart?
It's always helpful to get the update, isn't it? And we had a good go over this in the May audit committee and talked in particularly about some of the target scores and whether they remained realistic, so we can keep our eye on that. In terms of what's not on there, and you know, it isn't maybe something yet we need to concern ourselves about, but the general climate at the moment in the country about combination of inflation pressure, you know, significant pay rises coming through, associated potential industrial action, just to keep an eye on that, which we will do, but it's obviously a current environment question at the moment.
Thanks.
Thank you.
Thank you, Stuart. Anybody else? No, I can't see anybody. Oh, sorry, Hilary.
Sorry, popped in at the end. Just a comment really about this, but also the BAF. Once we've approved our new strategy, just thinking the meetings that we've been having where we've been setting new goals, etc., and targets, we're just going to have to relook at our BAF, aren't we, and our risk register as well, to make sure everything's aligned to our new strategy as well. So just sort of being aware of that, particularly I think the biggest changes we'll see are on the BAF.
Thanks for that heads up, Hilary. Thank you. Very helpful. Okay, good. Thanks, Oliver. With those sort of suggestions, please, thanks for your time and thanks for holding on as well, because we were a bit late coming to you as well, but appreciate that. Thank you.
No problem. Thank you, everybody. Thank you for the feedback. See you later.
See you, Oliver. Bye-bye. So sorry about the mixed round on the agenda. So now we are doing the external wall-led review action plan update. It's swapped with the equality delivery system. So, Michelle.
Thank you, Chair. So this is the latest presentation of progress against the action plan, which was agreed. We will present monthly to board right through to completion. So the updated plan demonstrates that progress is being made against actions to address the recommendations from the external review. All actions are underway, are on track for delivery. Just to highlight a couple, the adverts for the Freedom to Speak Up ambassadors have gone out, and an update on that action in June will be, we're still in June for a couple, so in July we will have a more thorough update. And the BAF overarching statements against each risk, that has been prepared, but just due to annual leave and timing, we didn't get sign off. So that is in hand and will come back to board as soon as possible. So good progress, everything on track, and as we already know, a review of embeddedness when we close this will be undertaken in Q3, just to look back on what we said we did and that it is embedded.
Thank you very much, Michelle. Any questions or comments from anybody on this? Okay, just to add, on Ned's catch up last week, amongst other things, we had a bit of a discussion about visits, and Ned colleagues have provided me with some comments, which I'm compiling and putting together and share. Also with governors, we had a bit of a discussion about this as well. So it'd be great to get that sort of sorted and finalised, and certainly by the time we get to the COG on the 14th of July, they know where they are on this as well. So thanks for everybody's comments in relation to that. So if there's nothing else to add to that, we can now move on to the Collaborative Committee Assurance Report.
Thanks, Chair. Hopefully you've had a chance to look at it. Again, I stood in for Stuart, who was not available, which is fine. There for assurance, I think it's quite clear. We've discussed a lot of the things before. Some really good work being done in relationship to the Collaborative Committee. Obviously, we had a really good, well-led review in relationship to the governance of that. The Shone Clinic remains the main issue that we're dealing with, and the team are dealing with it exceptionally well. And we know that we're liaising very closely with the Shone Clinic. But I'm going to leave it there, Chair, and just ask for any comments or questions that people may have.
Thanks, Michelle. Any questions or comments? No? Okay, so that's received and noted. Stuart, you're going to give us a verbal update on Audit Committee Assurance?
Yeah, this is just to report back from yesterday's Audit Committee very briefly. So we had a very successful meeting, the result of which is that we've lodged, I think this lunchtime, our accounts and annual report. And once the auditors have completed all of their work and we're ready to publish, we will put our annual report and accounts into the public domain. And without kind of giving too much away, but in terms of what will be produced, we're in a good place with good endorsement from the internal and the external auditors and the counter fraud team we work with, and we'll be presenting a positive outcome on our financial performance and our business performance in the near future. So that's it for this meeting.
Thanks very much, Stuart. Any comments, questions? No, thank you. So that's noted. Items for escalation. I don't think we have any. Michelle, have we? No, thank you very much. So we move to any other business, and this is a good opportunity, and there'll be others, just to say something about two of our colleagues who will be leaving shortly, John Byrne and Michelle Hughes. I think, John, this is your last board meeting. You may be relieved at that, or you may not, I don't know, but I'm sure you'll say. And although Michelle is around in July, we thought it's an opportunity to express our thanks formally here to both of you for your service, your contributions, your humour and your input, and what you bring to our conversations. But I've only known the both of you a relatively short time. Thank you for your support to me. Thank you for the discussions we've had, and most of all, thank you for what you do. And I know from speaking to others in the organisation, not just on the board, how valued your contribution has been. So let me pass on to others who know you better than I do, who can hopefully add to what I've just said. Michelle.
Well, thank you. I mean, John is a legend in his own lifetime, I think, is suffice to say. But and we are getting nods around there, so there's not really much else for me to say, and it's difficult by teams. But I'm going to start with Michelle, because Michelle is with us in July, but I think on holiday for the next board meeting. But Michelle actually just came very much like me for a few months and has stayed for years and has been. Has been retiring for about 3 or 4 years, but I know that Michelle's going on to a retirement somewhere sunny, because those of you who know Michelle know that she likes to be in the sunshine constantly. So I wish you all the best, but do remember your factor 30 and your factor 50 and the after sun as well, Michelle. But I'm no doubt we'll keep in touch, as I will keep in touch with our eminent medical director, who is going down to London with his skill set and his skills. And John, again, only came for a few years, actually. I remember when we interviewed him, he said, I'm only going to be with you a few years, you know, and then I'm going to think about moving on, and I get itchy feet after a couple of years. But he's been actually with us for 4 years, 9 months, and it doesn't seem any longer than 10 years for me. But what else can I say about John, other than I am not going to mention rugby at this stage, but I am really going to miss his bantering relationship to rugby. But seriously, I think for me, and it's difficult with leaving dues, etc. I know that John's a bit under the weather today, but just to say that he has been a remarkable medical director and medical leader for the organisation. We hear constantly about the journey that we've been on over the past 4.5, 5 years, and John's been a key player in that. And I thank John for his support and his challenge, because I think that's really important, and his comments. You know, he does bring some different perspectives on things, which is fantastic. I will miss him. I'm sure his colleagues, I know his colleagues will as well. I will keep an eye on his career. And you know, we will keep in touch. But on behalf of the board, thank you so much, John, for all the work that you've done in improving patient care, patient safety, staff health and wellbeing, and the organisation, and helping us on that journey. And all the very best for your next journey.
Thanks very much. Well, I was going to say, does John want to have to say anything? But then, when did John not have something to say? So let's. Is any other members of the board would like to say anything at this point before I go to John and Michelle? Maybe. I think Michelle has wrapped it up. So let's go to John.
So, Michelle, I'd just like to say thank you very much for your kind words. Much appreciated. You've reiterated them publicly a few times, and I do appreciate that. And look, I'm just glad I had the opportunity to come to Humber. I don't think it was necessarily on my career roadmap 6 or 7 years ago, but things come along, you take the opportunities. And I've had a fantastic time personally and professionally working in the organisation. And we're not there yet, but I think we're way ahead of where we were 5, 6 years ago. And I'm particularly grateful to all of my colleagues, particularly in my team, who've supported me on the journey. And, you know, on a personal level, I'm just, you know, delighted we all survived COVID. And actually, I think that was the test of the organisation. We can talk about outstanding and all that sort of stuff, but ultimately the organisation went into COVID in a solid state and has come out of it in a solid state. And I don't think everyone else can say that. So if that's a mark of progress, that's good enough for me. But it's been a pleasure to work at board. I've thoroughly enjoyed the opportunity to give my opinion, whether it's been wanted or not. I've always given it. And I'm certainly convinced that my opinion hasn't always been right. But then again, you always have to have the opinion. So look, it was particularly pleasing for me to hear today the pharmacy story, because that felt like a little bit of lap of honour, because it just shows you what we can do with some really talented colleagues who are prepared to work differently and think differently. And that's just as much about the pharmacy team as it is about our operational colleagues who embrace pharmacy and all that it had to offer. And I think if we do the same thing right across the services going forward, we'll be certainly in a strong position over the next few years, because I think it's turbulent times ahead, and most of that is beyond our control. So thank you very much, everyone. I'm not leaving to pastures greener. I'm just going to different pasture. But as I said, sometimes John needs to come and John needs to go, and quit before the posse come and get me is what I'm saying. So that's always been my career ambition. So thank you very much for the opportunity, Michelle.
Thanks, John. Michelle?
Well, as you would expect, I'll have a lot less to say than John. Sorry, John. So you'll all see me over the coming weeks. So I'm not actually gone yet. So I will just say thank you for your kind words and farewell to John.
Great. Okay. Well, I think we will see some of us will see you again, but just to say we wish you all the very best, professionally and in your lives, going ahead, and yeah, we just wish you the best in whatever comes your way. Thanks so much. Great. Lovely. So that's the end of our meeting, and our next meeting's on the 27th of July. So thank you, everybody. We're finished.